This is lesson number 4 in the circulatory system on heart rate and blood pressure. Goals for this lesson are to be able to describe the relationship between pulse and pressure in the body, the way that our body regulates both heart rate and blood pressure through intrinsic and extrinsic controls. Again, in this slideshow, there are lots of videos linked, so please do open up this slideshow in Google Classroom and watch some of these videos. They're really going to help you to understand the different processes involved in managing heart rate and blood pressure. The heartbeat is controlled by heart muscle. Heart muscle is called myocardium. Myo is a prefix related to muscles, and cardium, of course, we've seen already, is related to the heart. So this is a specialized type of muscle tissue. Cardiac muscle is found only in the heart, and it enables the muscle to contract continuously without tiring. Your heart will beat for your whole life, hopefully, and that muscle needs to be able to withstand constant activity. Cardiac muscle coordinates the contraction of your heart in association with nodal tissue. Now, nodes is a type of tissue that has both properties of a muscle, given that it can contract, and nervous tissue, that it can send a stimulus message to other tissues. Hearts have 2 nodes, and they control the contraction of the atria and the ventricles and keep the heart rhythm in a normal status. First node is the SA node, or the sinoatrial node. It's found on the upper wall, or the sinus, of the right atrium. And the job of the SA node is to receive impulses from the brain and send that impulse to both the left and right atria at the same time to stimulate a simultaneous contraction. The atria always need to contract together. The ventricles always need to contract together. So the top of the heart contracts, then the bottom of the heart contracts. The SA node, after it's done its contraction, sends an impulse along to the AV node, which then controls the contraction of the ventricles. The SA node is also known as our body's natural pacemakers. And in people where they've had to have a pacemaker implanted, that's an electrical device that actually replaces the function of the SA node to keep the heart pumping in a regular rhythm. The AV node, or the atrioventricular node, is also found in the right atrium, lower down, closer to the AV valve. That's the tricuspid valve. The AV node receives impulses from the SA node, and that initiates a contraction of the ventricles. The message travels from the SA node along the Purkinje fibers. And those fibers stimulate contraction from the bottom up, so squeezing like a tube of toothpaste to get all the blood pumped out of the base of the ventricles, down here near the apex of the heart, and up and out the 2 vessels leading away from the heart, the aorta and the pulmonary artery. Now, action potential describes the depolarization and repolarization of membranes, and we'll come back to this in much greater detail in the nervous system. But this is how our nerves send signals around our body, and also how muscles receive those signals and contract. You can see that it is regulated by the movement of charged ions across a membrane, and that at rest, the membrane has a natural charge separation, where the outer extracellular area has a positive charge due to many sodium ions, and the intracellular, the inside of the cells, has a slight negative charge. There are positive potassium ions in here, but there are also large negative ions that are unable to leave. A here stands for anion, a negative ion. When this depolarization, repolarization action occurs, channels and proteins open up and allow for the movement of potassium and sodium in and out of the cell. This is a sodium-potassium pump, and it's an active transport method. In the cardiac cycle, that's 1 heartbeat, we have a few stages here. Remember that systole describes a contraction. Systole with an S, maybe you'll remember squeeze. That's where the vessels or the chambers are squeezing or contracting to push blood out. Diastole is the dilation phase, the relaxation phase. The first step of the cardiac cycle is where both the atria and the ventricles are relaxed. Step 1 here, atrial and ventricular diastole. Step 2 is where the atria contract. Blood is pumped from the upper chambers down into the lower chambers. And that's followed very quickly by ventricular systole and atrial diastole. The ventricles contract, push blood out, and the atria are relaxed, ready to receive blood at the next cycle. Remember that that's all controlled by the valves opening and closing. The lup-dub sound is the sound of our AV valves opening and shutting first, and then the semilunar valves opening and shutting second. You can see here again the phases of the cardiac cycle spread out a little bit more, and now along the bottom they've included a electrical impulse reading here. And so these will look familiar if you've ever seen a TV show where they have the heartbeat on a monitor, or if you've ever had a monitoring test done yourself. That squiggly line on the screen is representing the different electrical activity of the different parts of the heart. And so that squiggly line is actually called an ECG or an EKG, which stands for electrocardiogram. And it just displays the changes in electrical potential of the heart muscle. They've labeled it PQRST, and those just show the different bumps on the EKG. The P wave happens just before that atrial systole. So just as the atria begin to contract, that's that electrical signal from the SA node that says time to contract. That's here with that little bump, the P wave. This QRS complex is much larger because it represents the contraction of a larger chamber, the ventricles. And then everything has to reset and get back to normal, and that's this T wave, as the atria and the ventricles relax and the membranes repolarize, flip back to that negative inside, positive outside. Now, we won't ask you to read or interpret EKGs or ECGs unless you are planning on going to nursing school. This is probably all you're ever going to need to know. But some interesting things here. You may have heard some of these words, AFib or PVCs, if you watch a lot of Grey's Anatomy, and that's really what they're talking about, the different ways that those waveforms can indicate problems with the heart. Typically, an ECG or EKG has 6 or 12 different electrodes stuck around the body, and depending on where they are attached to the body, they show electrical activity in different parts of the heart. If a patient has a rhythm that is not normal, sometimes there's a need for a shock, and so then paddles will be applied and an electrical shock will hopefully reset the heart back into a normal rhythm. The QRS complexes, the high bumps, can help us to understand the heart rate as well. And so a normal heart rate, around 60 beats per minute is average. More bumps per minute is a faster heart rate. Fewer bumps per minute is a slower heart rate. And if the bumps don't occur in a regular pattern, then we would describe it as an irregular heart rate, sometimes called a fibrillation. Now, our heart rate is controlled in 2 different ways. The extrinsic control, that's the outside of the heart, is where our nervous system signals to the brain. Our nervous system, which is our brain, signals to the heart. So the medulla oblongata is part of our autonomic nervous system, which means that it is non-conscious. You never are thinking about your heart rate. And that is what stimulates the SA node. There are 2 different nerve fibers that attach to our heart. Part of our parasympathetic system is the rest and digest. It slows our heart rate down, and that sends signals through the vagus nerve. Helps to decrease our heart rate. I think parasympathetic, like paralyze. You're resting, you're relaxed, and your heart rate slows down. The opposite is the sympathetic nervous system. This is that fight or flight response. The adrenaline gets going and your heart rate increases. Those signals come down a different set of nerves, the sympathetic cardiac nerves, and those will increase the heart rate. The intrinsic control is the control that happens inside the heart as the SA node communicates to the AV nodes to coordinate the contraction of the atria and the ventricles. The other factor that we can measure when we're looking at cardiac function is blood pressure. And blood pressure is the amount of force that the blood itself is pushing against the walls of our blood vessels with. Blood pressure, if you've ever had it taken, is usually given as two different numbers. Your systolic pressure over the diastolic pressure. An average adult, a healthy blood pressure, would be described as being 120 over 80. The 120 is the systolic pressure. Remember that systolic is the squeezing pressure. It's a higher number because that is the pressure where the blood is being pushed out of the heart through ventricular contraction, and it's being forced through the arteries at its highest pressure. Diastolic is where the ventricles are refilling, and so there's not as much of a forceful push, and so the pressure is a little bit lower. This is between contractions of the ventricles. And so a normal diastolic pressure would be 80. The units for that are millimeters of mercury, and it's just a measure of force or pressure. Normally, blood pressure is measured on the brachial artery of the arm, so it's the upper arm, and the device used is called a sphygmomanometer. And how it works is first pressure is applied, that cuff around your arm is inflated until the blood flow actually is stopped. Once it's reached a higher pressure than the highest blood pressure your arteries are exerting, it actually collapses the arteries. And with the stethoscope at the elbow, you can't hear any blood flow anymore. As the pressure is released, blood flow resumes, and when the first burst of blood makes it through, that is measured as the systolic pressure. And then as blood flow returns to normal, that whatever pressure that occurs at is called your diastolic pressure. Blood pressure is not the same throughout the entire body. It's the highest at the beginning of the aorta. Just as blood is leaving the heart is where your aorta, your blood vessel, experiences the highest amount of pressure. In the ascending part of the aorta, pressures can be as high as 140 over 120, and that's a normal, healthy pressure. As the blood goes further and further away from the heart, traveling through the arteries, blood pressure gets lower and lower, and once it gets down to the capillaries, it's almost zero, between 40 to 10 millimeters of mercury, so a very low amount of pressure in those tiny arteries. And the reason for that is that although capillaries are very small, there are so many of them that the blood isn't forced in a high pressure situation through those vessels anymore. In the veins, blood pressure is also quite low. It doesn't have that pushing force of the heart, and blood has already been slowed down in the capillaries, and so the veins rely on those valves and the skeletal muscles to help push the blood back up to the heart. But the blood pressure is much, much lower there than it is in the arteries. You will see a diagram like this likely on a test or a quiz, and it represents a number of different factors and how they are related to one another. Over here in this pink side of the graph, we have blood flow through the arteries and arterioles. You can see closest to the heart in our large arteries, we have blood pressure that is the highest and that it oscillates with heart rate, and the velocity oscillates as well. With contraction and relaxation of the ventricles, we have increases and decreases in pressure and velocity. This curve here represents the cross-sectional area of the vessels. And so we can see that there is, as we get into smaller and smaller vessels, there's actually a larger and larger total area of all of those vessels in the body. Peaking here with the capillaries, where we have, I think it's 6,000 square meters of blood vessel cross-sectional area. And then starts to drop again as the blood vessels merge together and become into a larger and larger vein, ending eventually with the vena cava draining back into the heart. You can see that the velocity slows right down. The blood is flowing the slowest in the capillaries, And it increases again slightly in the veins due to the valves and skeletal muscle, but nowhere near as quick as it was in the arteries. Pressure follows a similar pattern. It dips down in our capillaries and then stays fairly low throughout the veins. Remember that veins have much thinner walls than the arteries do, and that the space in the veins is a little bit larger. And so we can see that the same blood in each of these vessels would feel a different amount or exert a different amount of pressure on the walls. The same amount of fluid in a smaller space is going to be pushing on the walls more than that same fluid in a larger space where there'll be just less pressure. Now, blood pressure can be affected by a number of different things. Vessel diameter affects blood pressure, and this is where the health of an individual can really come into play. We know that a larger blood vessel is going to have a lower blood pressure, and usually that's a good thing. Low blood pressure is healthy. Too low, however, means that blood may not necessarily be reaching all of the crucial parts of the body. And so if you've ever stood up too fast and felt that sort of woozy, dizzy feeling, that's likely because your blood wasn't reaching your brain as much as it needed to. And so that large blood vessel will lead to a low blood pressure. Smaller blood vessels is where we really get into trouble. If the blood vessels are constricted because they're stiffened or blocked, or with age don't have the same flexibility, then that can cause an increase in blood pressure. Higher blood pressure is much more dangerous than low blood pressure. The thickness of blood also affects blood pressure. If the blood is thick, doesn't flow very easily, it's very viscous, usually because the person doesn't have enough water, then they will experience a high blood pressure if it's not flowing very easily. Thinner blood will flow more easily and exert a lower pressure. Elastic vessels, similar to the vessel diameter, stretchy elastic vessels, healthy, low blood pressure, hardened or sclerotic vessels will exert a higher blood pressure. Blood volume affects our blood pressure as well. So lots of salt will cause your body to put more water into the blood to try and dilute that, which can cause a higher blood pressure. Lots of sweating means you're losing volume, losing salt, and your blood pressure is going to be lower. A higher heart rate also causes a higher blood pressure. Lower heart rate, lower blood pressure. And so those are sometimes a health factor and sometimes connected to age. But we know that as individuals age, no matter what they've done in their life, whatever health choices they've made, there is a loss of elasticity in the blood vessels. There's a loss of elasticity in lots of tissues as you age, which is part of the reason that wrinkles form, that the skin isn't as stretchy and elastic. And we also know that stress at any age can cause constriction of the blood vessels, which can cause an increase in blood pressure and has other health effects as well. So in summary, connecting our brain and our blood pressures and our vessels, we have the full pathway here, this connection of signals sending from the medulla oblongata in the brain, an impulse to the atria, the SA nodes cause the atria contract and our AV valves open. That impulse travels to the AV node through Purkinje fibers, and the AV valves close. That's that first heart sound. And the ventricles contract, atria are relaxed. We see that QRS on the ECG, and our semilunar valves open. As the whole heart rests, that's that repolarization, the T, that final bump, and our semilunar valves close. We get that dup, that second sound. And so a couple videos again in here, so make sure you go back and watch those. And next up will be blood.